Muito bom dia a todos e sejam muito bem-vindos à sessão Fighting Cancer. Vou passar para inglês porque temos um convidado em inglês e, portanto, good morning to you all and thank you for coming to the session Fighting Cancer. I will just present Professora Catarina Rezende de Oliveira that will officially start the meeting and I will not waste your time with my talks as we have not much time for all our ambitions. Professora Catarina.
Everyone, first of all, I'd like to welcome all of you in this Ciencia 2022 session dedicated to cancer, a topic that is one of the leading medical societal challenges today. So next slide, please. Next, please. Next slide, please. In this session, entitled Fighting Cancer, Portuguese and European Initiatives, we will start with a brief presentation of the actions developed by ICIB and DGS, namely those developed with the National Programme for Oncological Diseases, leading to the creation of the National Cancer Hub that will be presented by Patricia Calado, and to the development of the National Strategy for Cancer Control that will be presented by Isabel Fernandes. Then we move to the communications by invited speakers. Professor Walter Ricciardi, Chair of the Cancer Mission in Horizon Europe Programme, Carlo Oliveira, Principal Investigator in I3S at the University of Porto, Sérgio Dias, Principal Investigator in IMM, University of Lisbon, Francisco Cavaleiro de Ferreira, President of the Portuguese Cancer League. To all of you, thank you so much for having accepted to participate in this session. And finally, in a roundtable discussion, the audience we will have the opportunity to put questions. Next slide, please. Why is ICIB involved in the organization of this session? So ICIB incorporated into its mission and vision the promotion of clinical research and biomedical innovation at the national level. Next, please. Developing for this purpose various activities organized in 5 action lines, one being devoted to the European framework programs. ICIB hosts the national contact points for European programs in the area of health. Next, please. And also by launching several programs aiming to strengthen the link between clinical and translational research and healthcare, including to drive innovation across the whole cancer research, care, prevention continuum. Next, please. Aligned with the Europe's Beating Cancer Plan objectives, a national cancer hub was implemented, which we believe is essential for a mission-oriented approach to cancer. Next, please. Finally, we would like to renew our thanks to the speakers who will share with us some of their experience and know-how. And to Professor Walter Ricciardi, we would like to address a special compliment and thank you so much for having accepted to join us today. ICIB team would like to reinforce its commitment in promoting the quality of clinical research at the national level and the projection of Portugal in Europe, particularly in the field of health sciences. Next, please. So we would like to reinforce once again our commitment to the field of health sciences, and we will be ready to answer to all our questions in this area. I wish to all of you a fruitful discussion and a successful session. Thank you for your attention.
Thank you, Professora Catarina Rezende. Our next speaker is Dra. Patrícia Calado, a former member of IEC and currently an advisor of us, and the co-coordinator of the Portuguese Cancer Hub, which is exactly the subject that brings her today here. Patrícia holds a PhD in biomedical sciences and has a well-known experience in the fields of research and innovation, research management, EU funding, and policy analysis. Patrícia Calado is currently the Vice Dean for Research at Nova Medical School. Please, Patrícia, come and tell us about the Portuguese National Hub.
Thank you. Good morning, everybody. Special good morning to Professor Ricciardi that is joining us from abroad. It is my pleasure to be here with you today and to present to you our efforts that we have developed in the past several months at national level for the creation of the National Cancer Hub. Very brief context because we don't have much time, and I think everybody is well aware by now that cancer is a political priority for the European Commission since the first days and speeches of the current President Ursula von der Leyen that asked the Commissioner for Health, Stella Kyriakides, to develop a plan so that Europe could fight cancer. And so it was. And in October 2020, in the scope of the European Framework Programme for Research and Innovation, Horizon Europe, that started in 2021, we had the first presentation, the first proposal for what is now established and up and running, the Mission on Cancer. And a few months later, in February 2021, the Commissioner for Health, Stella Kyriakides, presented the Europe's Beating Cancer Plan. This plan is the big umbrella that guides all the strategic initiatives for cancer in the European Union. It covers all the pathway, all the disease pathway, and it includes 10 very ambitious flagships. Many of these flagships will be delivered through research and innovation. So the mission on cancer is completely interlinked with the European Beating Cancer Plan. The European Beating Cancer Plan, it's a strategy, it has no financial envelope, and will be implemented through other European initiatives. In terms of research and innovation, it is the mission on cancer that will contribute to the goals of the EBCP. And for this reason, the European Commission had to establish a governance at the European level so that these two initiatives would be managed and governed together. And this is not the point of our discussion here, but it's important for us to understand that at the EU level, we have the different DGs from the Commission working together, mostly DG Santé and DG Research. And then we have the countries working together too. A new group was created to put together all the member state representatives and the European Commission. We call it a subgroup on cancer. And also we have all the stakeholders that want to participate were called by the Commission to integrate what the Commission calls the Stakeholder Contact Group on EBCP. So all this is by now up and running at the EU level. But we need to make things happen at national level. So we need to have some kind of structure and coordination at national level. And this was the challenge that we faced and we embraced in Portugal and also in other countries. So we created what we call the National Cancer Hub, which is a hub with a goal to coordinate, promote and support the implementation of the European cancer initiatives in Portugal. So we want to use this hub to define actions, to define funding strategies that will be in line both with the European Beating Cancer Plan and also the National Cancer Control Strategy for 21-30 that my colleague, Dr. Isabel Fernandes, will tell you a bit more about. So the main image that you have to keep in mind is that we have a strategy that runs at European level. We have a strategy for cancer control that runs at national level. Obviously, they are in line. And for the following years, we have several programs. In this case, we are talking about European initiatives that will fund and leverage these strategies. And we want to have this coordinated at national level. We created the National Cancer Hub that consists of two different groups, a stakeholders group and a policy group. And we believe that by putting these two groups acting together, we will contribute to having and creating impact at national levels for Portuguese citizens, patients, and for our national healthcare services. Very briefly also, this is the constitution of our policy group. The policy group, it's constituted by representatives of national institutions that were nominated by both the Ministry of Science, Technology and Higher Education. And here we have ICIB, the Agency for Clinical Research and Biomedical Innovation. We have the Foundation for Science and Technology, the National Innovation Agency, and the Portugal in Europe Research and Innovation Network. And then we also have representatives nominated by the Ministry of Health, the Central Health Administration, where we have the Director General for Health, represented by the National Program for Oncological Diseases, and we have the Regional Health Administrations, and also our three national cancer centers. This group was nominated in November 2021. And the main goal, and this is a big challenge, but it is what the Commission would like to see with the EBCP and the Mission on Cancer, it's the uptake of the solutions, technologies and scientific evidence into the health systems and into the national health policies. And this is the main goal of this group. So inside the group, we have discussions in order to define strategies, funding actions, and of course, we also discuss how we can participate in actions that the Commission launch and are aimed at the national authorities. We had the first meeting of this group, I think, in January, and we have been meeting regularly every month since then. And then we have the stakeholders group, which was created by an open call for expression of interest that was open roughly, I would say, like a month to all the community, research institutions, patients, civil society, industries, whoever wanted to join and felt that had a contribution or a special interest on cancer. So currently we have around 300 members, mostly researchers and health professionals. And the goal of this stakeholders group is to scout for funding opportunities in EU and national programs, to identify priorities, this is very important, and then these priorities can be funneled back to the policy group. We will create thematic working groups inside the stakeholders group, and of course we want to promote synergies inside this group and foster the participation of our organizations in European research projects and networks. We had the first meeting on the 1st of April, and two initiatives came out of this first meeting of the stakeholders group. So the first of them is the creation of what we call the thematic working groups. These working groups are the ones that will be proposed in the National Cancer Control Strategy. Groups on prevention, early detection, diagnostics and treatment and survivorship, and then transversal areas, pediatric cancer, health information, research and development. So anybody that is in the stakeholders group can propose to participate, to take part of these thematic working groups. Preferably around 12 participants and preferably people that are representing their institutions. We are currently performing the selection. And also, after this first meeting on the 1st of April, we asked all the community, because it's not just creating a group, saying I want to be a member and waiting for something to happen. So we want these 300 members to to engage with the group, to really have empowerment. So we ask all of them to propose ideas, initiatives that they would like to see implemented in Portugal, but not only proposing, explaining how they could be implemented and how they could help and contribute to those ideas. We had several very nice ideas, which we are now reviewing, and will then come back to join everybody in a second meeting in the next months. So this is what we call our National Cancer Hub, policy group plus stakeholders group, meetings ongoing regularly, and I think that this will leverage our initiatives at national level, and we are open for discussions and questions later. Thank you so much.
Thank you very much, Patricia. It is my pleasure now to invite Professor Isabel Fernandes to take the floor. Isabel Fernandes has a PhD in Strategic Management of New Drugs in Oncology. She is a medical oncologist at Santa Maria Hospital and invited professor at the School of Medicine of the University of Lisbon. Isabel is also representative in cancer-related groups of the European Commission, as one that Patricia just mentioned, and an associated to the head of the National Program of Oncology Diseases. Today, Isabel will provide us an overview of the new National Cancer Control Strategy 2021-2030. Thank you.
Good morning to all. It's a pleasure to be here today. I would like to thank the organization, to ICIB, to Patricia, to Hugo, and everyone that invited the National Program for Oncological Diseases to be here. I'm representing Dr. José Diniz, which is our director, and I'm also representing the Directorate General of Health from Portugal, and I will present the National Cancer Control Strategy for the next decade. This will be the it's not passing, I think. It's not passing in here. So, okay, I will try to speak a little bit before the presentation is on. But more than that, I think Professor Patricia Calado already presented some of the things. We are already working together. We have already some collaboration with ICIB in the National Program for Oncological Diseases, and I don't know why it's not the presentation, but I will speak without that. Okay, we have a vision. We want to be aligned with the Europe's Beating Cancer Plan, because the Europe has main goals that we need to be aligned with them. So we need to have a strategy in order to accomplish that aims. Our vision for that strategy is a patient-centered vision. I will show you then, when the presentation is on, all the idea in a more easier way to see it. And we also want a collaboration with other ministries besides the Ministry of Health. In fact, why this is so important for us? Because at the moment, cancer is the second cause of death in Portugal. It's more than cardiovascular diseases at the moment. And we already have some numbers, and in 2018, we had more than 50,000 cases, new cases. So we need to have some strategy to minimize this impact in incidence and prevalence. So it's difficult to go on, but then I will show you the presentation in a quick way. When we decided to do this strategy, we aligned this with the European one. And you also already saw the groups that were defined. We have 4 pillars for clinical actions. One is the prevention. The other is the early detection, in which, but not only, but in which we have the screening programs. We have the 3rd pillar of diagnosis and treatment, and a 4th pillar of survivors. And this is a difference, because if you read the ABCP, you have in the 4th pillar quality of life and survivors. We only put then survivors alone, and we consider the quality of life in all the 4 pillars. More than that, we have 3 cross structures. We have transversal groups. Why? We have 3 groups that are transversal. One is pediatrics. We have a problem. Everyone wants to know more about the pediatrics, and the pediatrics has a lot of things in prevention, early diagnosis, diagnosis and treatment, and also survivors. You have survivors that are pediatrics. So what we are going to do to the children? More than that, we have another group that is information in health. And in here, we can consider the digital transformation, and we can also consider the data. It's a very, very important thing in all the pillars. And, but not least, the research, and the research is transversal to all groups. So when we did our organigram, after that, I will show you the slides very quickly, only to do the main messages that I'm trying to transmit to you. But we want this to be aligned with the main goals of Europe, and to be aligned with everything what is already being done with the stakeholders group and in the National Cancer Hub. So we don't have yet the strategy completely approved. It will be put for public presentation I hope in the next month. It's already approved by the ministry, but it's not yet published. And that, when it arrives to all of you, you will be able to give your position about that. Yeah. No. It's being difficult. Okay. So can I go a little bit? So now I will be very fast, because I already spoke about almost everything. So we have the context, the vision, the goals, and the governance plan. I already said that. You see that cardiovascular diseases are decreasing, so we have a problem with cancer. We have the new cases published by National Oncological Registry, and this is our vision. This vision is already ongoing, as you saw in the previous talk, and we want teamwork, communication, and motivation. All of us will need to work for this to go away and to accomplish all the goals. So in the 1st pillar, we want to promote physical activity and healthy eating, mitigate exposure to oncogenes, legal regulation and tax harmonization. Of course, this is important. We want to prevent what is preventable. When we came to early detection, we want to ensure fair and quality access to screening, ensure quality and safety of procedures, ensure training of professionals. And in the diagnosis and treatment, which is a very huge pillar, we want to have a formalization of oncology referral network. It is a network that is for each type of cancer and not for specialty. That is what is ongoing at the moment. We want to qualify the access and increase equity, and we want to value professionals and institutions. In the survivors group, we want to promote social and financial equity and to have morbidity measurement in survivors. So this is what I was talking about. In here, you can see the organigram. This executive commission is already ongoing in this, we call it the despacho group. because it's already published in a portrait in our legislation, and we are already working on that with ICIB, and we have several groups in each one of the pillars, and the cross structures that I have already talked about. I won't repeat everything because we don't have so many time for that. So, in summary, we want the formalization of the National Plan Against Cancer, leveraging existing national institutions and mechanisms, streamlined procedures, coherence and transparent promotion, health system empowerment, funding opportunities under the ABCP optimization. All the strategy is also to try to apply to the funding opportunities. And this is very important. I hope it will be put and published in a few weeks. I don't know. It don't depend on me. But thank you very much for your attention. And I'm sorry for the problem with the presentation, but it was what. Thank you very much.
Thank you very much, Patricia and Isabel, for presenting us the National Cancer Hub and the National Strategy for Oncological Diseases, essential for a coordinated national approach to such a tremendous challenge. The next part of the session is dedicated to the EU Cancer Mission and how national research and civil society align with the three of the four main goals of the EU Cancer Mission. So it is my pleasure to present Dr. Walter Ricciardi. Walter Ricciardi is a professor of hygiene and public health at the University of Università Cattolica del Sacro Cuore of Rome. Professor Ricciardi has a vast and notorious curriculum, as you may know. He is a scientist, a scientific advisor to the Italian Minister of Health for the coronavirus pandemic and the scientific director of Istituti Clinici Scientifici, I don't know to read so much well Italian, so Moghery. Founder and currently the director of the Italian Observatory on Healthcare, president of the World Federation of Public Health Association, chair of the EU Mission Board Cancer, and this is exactly the main reason for having him here today with us, editor of several scientific journals, coordinator of various international projects, namely the Project to Reach, the first program funded by the European Commission dedicated to the health services and health systems research. Among his several distinguished international positions and prizes, he has received the Laureate Honoris Causa at Thomas Jefferson University, Philadelphia, USA. So today, Professor Ricciardi will tell us about the EU Cancer Mission that I'm sure you are all looking forward to hear, and I thank you very much. And Professor Walter, the floor is yours. Please.
Thank you very much. I hope you can see the slides that I prepared. Yes, here they are. And essentially, they speak about, can I have the next slides, about the mission. The mission is a new kind of initiative of the European Union that is essentially inspired to the mission that JFK, John Fitzgerald Kennedy, launched in the early 60s in the United States, the mission to the moon. The missions provide a solution, an opportunity, and an approach to address the numerous challenges that people face in their daily lives. And there are 5. I don't know if you can see the next slide. Yes, next slide, please. Yeah, and is to give directions to European research and innovation in solving society's pressing challenges and produce tangible results, and to involve citizens and stakeholders more closely in setting research priorities, which will lead to equal access for everyone in Europe to the best of European innovation and research resources and global know-how. The missions are 5. One is about climate change. The second is about food and agriculture. The third is about water and fishes. The fourth is about smart communication and urban health. And the fifth is cancer. Next slide is exactly about cancer. Why cancer? Next slide, please. Cancer is a problem for the world, but it's a particular problem for the European Union because the number of new cancer diagnoses in Europe is projected to increase by 25% by 2035. Just to give you a proportion, Europe, with 10% of the human population, has already 25% of the global burden of disease. If we don't act now, it will have by 2035 the 50% of the burden of disease globally. So we need a better and equitable prevention and diagnosis, treatment and care, survival rates, and post-cancer quality of life. If you go to the next line, you see what essentially the mission cancer is. This is a mission where the Horizon Europe program will provide to fund with 378.2 million in the period 2021-2023 to support the implementation of the mission, to implement a strategic research and innovation agenda to better understand, prevent, screen, diagnose, and treat cancer, and to improve the quality of life of patients and their families, to establish a high-level collaboration within the cancer community, and in particular also with the collaboration with citizens and patients. The mission has been co-created with them, and to set up the EU platform Understanding Cancer, a network of comprehensive cancer infrastructures, and the European Cancer Patient Digital Center. In the next slide, you see essentially the result of our work in the first 3 years. So the goal is 2030 to save more than 3 billion lives and to grant European citizens to live longer and better. We have structured the program according to 5 intervention areas. One is understanding research, which of course is a cross-cutting activity for all the 3 pillars of the mission, which are prevention, diagnosis and treatment, and quality of life. And all of this in the framework of a more equitable access, because Europe has incredible inequalities in both access to each of the preventive, diagnostic, and treatment strategies, but also in the quality of life according to the different indicators that we already have in mind. In the 3 years of our work, we have produced a plan, next slide please, with 13 recommendations. You can see there are 2 recommendations with understanding and research, 2 recommendations about preventions, 2 recommendations about diagnosis and treatment, 2 recommendations about quality of life, 2 recommendations about equitable access, and 3 recommendations concerning the cross-cutting actions. And next slide, this program was accepted and launched by the Commission in September last year, together with the other 4 missions. All of them have been launched and making Europe the best possible place to tackle these challenges. Next slide. I will go in only, of course, the first action, which is the launch, which is the Horizon mission UNCAN EU, which is a European initiative to understand cancer that is already being launched and funded. The scope of this concerted supported action is addressing integration with research infrastructures and European reference network, to create sustainable and interoperable data platforms, to integrate with other platforms proposed under the cancer mission, the cancer plan, the mechanism for determining clinical priorities, equitable access, engagement with citizen and patient advocacy organization, utility, feasibility, sustainability of the program, and take into account also the newly EU-funded initiatives such as Healthy Cloud, EOSC Life, and EHDS joint actions, essentially very important. We don't want to reinvent the wheel, but we want essentially grant continuity with other programs that are essentially important to grant our actions done effectively. In the next slide, you see already the actions that have been proposed for 2021, proposed and funded. As I said, the UNCAN.EU has been launched, but there are also some concrete research actions that have been funded concerning screening and early detections, the development of new methods and technologies for screening and early detections, for concerning quality of life, the establishment of a framework to collect and analyze data on today's unmet need of cancer patients and survivors, and also 2 support actions. One, the network for national cancer thematic mission hubs and the blueprint for the European Patient Digital Center. In other words, for the new institution where all citizens of the European Union can essentially share their data and possibly share the possibilities of having the best possible access to research, diagnosis, and treatments independently of the place where they live. Next slide is about the mission program already funded for 2022, which is about research actions on understanding to better understand cancer and study patient-tumor interactions in poorly understood childhood and adult cancer. Concerning prevention, to conduct implementation research on cancer prevention. Just to give you an idea, you cannot be serious to tackle cancer unless you also tackle the commercial and social determinants of cancer, which of course is food, nutrition, physical activities, alcohol, tobacco, chemical pollution. So these are something where we have to do more in a much more coordinated way. And last but not least, diagnosis and treatment, so clinical trials on treatments using personalized medicine approaches and the focus on improving quality of life. And finally, next slide, please. There are already some related actions to the Mission Cancer and the Cluster Work Program 2021, which have been funded. You see the budget and you see the deadline that has already been inspired. For instance, the improvement of supportive palliative survivorship and end-of-life cancer patient, the data-driven decision support tools for better healthcare delivery and policy making with a focus on cancer. Next slide, please. The fair and open data sharing in support of cancer research and the research infrastructure services to support research addressing cancer. I think it's very important that member states approach this challenge and this mission in a coordinated way. So I'm delighted, as Professor Calado presented, that Portugal has organized a coordinated strategy. Each of us has been a kind of ambassadors to different member states in order to make understanding that these are unique opportunities to fight cancer and to improve quality of life of European citizens. And Europe is the place to stay because you may be aware of the fact that twice the United States have tried to launch and approach a similar program, failing because of a lack of coordination and because of a lack of support. In Europe now we have the share of value related to the fact that the right to be cured and the right to prevent cancer is a moral right that we have to grant to all citizens, and also the funding to make it real. So thank you very much for your attention and all the best for your work.
Thank you very much, Professor Ricciardi, for such an enlightenment talk. With no further ado, it is my pleasure to introduce Carla Oliveira. Carla Oliveira's research aims at finding biomarkers with clinical utility for earlier detection of sporadic and hereditary gastric cancer, and to disclose actionable genotype-phenotype relationships in these diseases. The social and economic impact of hereditary cancer is transversal to her research, and it is clearly illustrated with the interaction with different patients' associations, such as Evita, for which she was awarded with a prize by Fundação Amélia de Mello recently. Today, Carla will tell us more about her work and how it aligns and contributes to one of the main objectives of EU Cancer Mission, namely prevention and early detection. Just allow me to... Carla, I believe the floor is yours.
E agora? Peço imensa desculpa, podem voltar, por favor. So, thank you very much, and I'm sorry for this delay. So I was thanking the organization for the invitation to be here today. I'll be talking about prevention and early detection of cancer. This is actually the research of my research team at I3S in Porto. Can I please? And I brought you two examples of the type of research that we do. And an example is on primary prevention and the application of risk reduction measures in genetically determined diseases. And the second one is an example of secondary prevention, where we have discovered biomarkers for detection of early aggressive disease in early stage cancers. Can I have the second one, please? The third one. And the disease we have been working on is gastric cancer. So the clinical setting and susceptibility is not particular for gastric cancer. And in this case, we have 90% of the cancer occur in a sporadic setting, and 10% of them are familial or hereditary. And these ones are mostly genetically determined from birth. And that means that we can identify the causal variant that occurs in these families and that is inherited from generation to generation. Once we detect that alteration, we can actually predict the occurrence of disease before the disease occurs. Can I have the next? And I will focus first on the hereditary setting. And in this hereditary setting, we have, as I told you, approximately 1% of the cases that have a high penetrance genetic susceptibility cause and very high risk of disease. Next. And so just an example, there are approximately 1 million gastric cancer cases worldwide every year. If we aim at finding 1% of them that carry a germline defect, that means that we can identify the families of these patients that harbor gastric cancer and find their defects and predict that they will have a cancer prior to its development. And eventually we may prevent disease, or we can treat it because it will be found. It will be found at early. Next, please. So the syndrome I would like to bring you is called hereditary diffuse gastric cancer. It has a population incidence of 5 to 10 cases per 100,000 births, so it's a rare disease. It targets stomach and breast and two very specific types, histological types. The more very high for diffuse gastric cancer and is moderated for lobular breast cancer. Next, please. Another one. And so this is just a representation so you understand that the cancer in these patients are multifocal and they spread in the stomach, very difficult to identify. And the cancer in the breast is also quite difficult to identify, but my MRI is possible to be used. There are two genes, CDH1 and CTNNA1, that cause this disease in different frequencies. I will focus on CDH1 just as an example. Can I have the next one? And the clinical presentations, and as you see, they are diverse, but a common feature is the early onset. So you have cancers in people with 23 or 17 years old. You have families that have both diseases, breast and gastric cancer, and families that have only one of these diseases. Can I have the next one? The criteria to define these families have been evolving, but we need to know which are the variants that are considered actionable. And being actionable, next, are the variants that are classified as pathogenic or likely pathogenic, and this occurs because they are able to disrupt the function of the protein and also to be present in many families with disease. This allows us to classify them as pathogenic or likely pathogenic, as they do not appear in normal populations. Can I have 2 clicks? Okay. Previous one, please. Previous. So this is highly penetrant. So males have a risk of 75% of probability of developing cancer by the age of 85, and females have a 60% risk of developing gastric cancer by the age of 85. Additionally, breast cancer may occur in families, in these families, and the risk is additionally 60%. And next slide, please. So if in CDH automatic carriers, so these people carrying these defects but are not yet sick, pre-symptomatic testing and the identification of a predisposing variant allows disease prevention. Next, please. So what can we do to identify this? We need to have clinical criteria to spot them. We need to have genetic testing to identify the causative germline defect. And then if patients are positive, we integrate them into program of for risk assessment and application of risk reduction measures. Next, 2 clicks. And to prevent the diffuse gastric cancer, we perform risk reduction gastrectomy early in life in 20s or 30s, and we perform, for those refusing, we perform surveillance by gastroscopy and multiple biopsy. Another click. To prevent breast cancer, we bilateral surveillance by the age of 30 and surgery to remove early lesions, but we can also perform prophylactic mastectomy. So the question is, who should be tested? Who should undergo risk reduction measures, and to understand if all variants are actionable or not? And these are the questions we have been playing. Next, please. And for this, we engaged with the European Reference Network Genturis and with this student, Giuseppe Elias, under the program SolveRD. It's a European project. And we collected 854 families from all over Europe, and this was a tremendous effort, and 2,000 phenotypes. Can we have the next? And we addressed the questions we wanted with this previous one, sorry. Next. It's quite difficult to do with this one. But okay, so the first thing is to understand whether the clinical criteria are correct, because this will tell us who should we test. And for this, we have the criteria have been evolving through time, and lately we have found an entity that is only occurs where only lobular breast cancer is found, and we need to understand whether that is the case or not. Next slide, please. And we understood that actually that is a very rare event. And you can see here in the middle panel that families with breast cancer only are very, very rare. And most of the families are found in the upper and lower panel together with breast and gastric, and this is seen by the color blue and pink. What you can see also here in small squares, it's that many families remain without criteria. Can I have the next one? And this means that the criteria that we have are not enough to find all the families that have mutations, because we find mutations and we don't find, and the people do not have criteria. So we need to understand that most families that fail to comply with clinical criteria, they actually have breast cancer only or gastric cancer plus breast cancer. And the breast cancer is missing in our criteria. We need to improve that, and this is something we have done only with the fact that by having all these families together. Can I have the next one? So the other thing was to understand the type of mutations that we should test, that are actionable. And on the top left, you have the ones that have families that have pathogenic and likely pathogenic variants, and lower you have families that have variants of unknown significance. And for those ones, we can't do anything to patients. We can't do prophylactic measures. But if you see the profile and only the profile between the upper and lower, the profile is exactly the same. So we have selected variants that are of a known significance, but behave the same way as the pathogenic ones. And this created the opportunity to identify more families and to do predictive and risk reduction measures in more families. Can I have the next one? So overall, this brings financial and social benefit. Because what we have seen as well is that the being affected often leads to death early in life, and the cost of treatment is very, very high, as opposed to where we identify patients that are asymptomatic, we perform risk reduction measures, and the cost is. And for those that are negative, with a simple test, they remain without need for care, clinical care. And the prevention is great for patients and the national health systems, and brings benefit to the population. It's only the subject of a project that we recently submitted to EU. Can I have the next one? So I'm just very briefly bringing you to an example of the second example, and I will be really brief. Can I have the next one? And this is a comparison between South Korea and Portugal. In South Korea, the incidence, previous please, the incidence of gastric cancer is really, really high, but as compared to Portugal, but the number of deaths is very similar. So we compared two series of chemo-naive patients. Can I have the next from Hospital Saint and South Korea? And what we saw, as expected, was that the survival was much better in South Korea in all stages. So we thought if we could find the reasons why this is happening and find markers to understand this is happening. And so what we did, what we realized was by using abnormal expression and CD44 V6 very high expression, these two markers, we could spot a number of patients on the left-hand side from the Portuguese cohort that had very, very bad prognosis. And this on the right-hand side, this was not the case for the Korea. So these markers could spot the poor prognosis patients in the Portuguese cohort, but were not good enough previous to identify the patients in the South Korean cohort. What we read, previous slide, please. Yes, so these tumors were equivalently deleterious in both cohorts, but the survival only bad in the Portuguese cohort. Can I have the next? And what we found was that in the Portuguese cohort, early cancers were detected 10 years later than in the South Korean series. Moreover, the early cancers in Portugal were mainly stage 2, while the early tumors in Korea were mainly stage 1. And this means that they are using population screening programs to identify gastric cancer at early stages, as opposed to Portugal. Can I have another one? And additionally, the surgical strategy in Korea is also very different. What they use is a radical gastrectomy with the removal of many more lymph nodes than we do in Portugal. And this is also the reason why they have less cancer. Can I have the next one, please? So survival, we defined the survival disparities between Eastern Asia and Europe, and with Portugal cases, and this may be explained by earlier action in the Asian cases based on population screening and surgical removal of lymph node metastases that eventually would metastasize and kill the patient. And so we also found cancer to biomarkers that can be used to spot these cancers at the early stage, as they confer aggressive features to these tumors. So I thank you very much for your attention, and all the collaborators and scientific institutions and funding agencies. And I'm really sorry for this back and forward presentation and quite confusing somehow. Thank you.
Thank you very much, Carla Oliveira. Now the next speaker is Professor Sérgio Dias. Sérgio Dias has a PhD in tumor immunology. He is a PI at the Molecular Institute, Medicine Institute, and an invited professor at the medical school from the Lisbon University. Professor Dias is also the coordinator of the IMM Laço Hub, an initiative that promotes the multidisciplinary approach involving scientific research with the civil society through knowledge, technology, and clinical practice. At IIM, he is the coordinator of the IIM Biome Bank and the coordinator of the National Biome Bank infrastructure. Sorry. So, Sergio, please come and tell us a bit.
Thank you. Good afternoon to you all. I'll be extremely brief because Patricia is in apoptosis. So what I'll do very briefly is I don't need to explain to you why it is important for us to study cancer. So I'll give you very, very briefly a couple of examples from research done in my lab over the last 15 years or so, which overall focuses really on finding biomarkers of disease progression and response to treatments, as you will see. So the advantage or the importance of research for cancer diagnosis and treatment is obvious to us all in this room, and millions that will look at the film afterwards, or the images. And so what we've done is we've gone from a stage of cancer diagnosis and treatment where it was one size fits all, meaning one treatment would fit all types of cancer. And now we are more and more approaching the stage where for each cancer in each patient, we do need specific characterization of biomarkers and of disease progression markers overall. Obviously, a lot of research has been done in cancer over the last 2,000 years, if you like, and this led to the generation of this particular wheel of the hallmarks of cancer, which basically characterize every single property that all cancers share. So if someone asks us what is a cancer, we should be able to summarize it by saying that a cancer will have these properties. And one may be more exuberant than others, but all share these properties. And obviously this was the result of a lot of years of research, as I mentioned. So many years ago, we focused on one particular aspect of cancer, which has to do with cellular metabolism and the host metabolism. And for a number of reasons, we focused on obesity and particularly on LDL cholesterol. And our question is summarized here, whether a systemic metabolic stress could act as a selective pressure, and specifically in breast cancer. We published a number of papers, a number of clinical papers, translational research papers, and more basic research papers. And on the basic research side, basically what we were able to see was that if we use mouse models of breast cancer, and basically we generate a diet that is similar to an obese-promoting diet, if you like, in the mouse, and this is not novel, this has been used for a number of years, basically what we see is that the progression of these breast cancers, regardless of the hormone status of the cancer itself, is faster. So it progresses faster. The tumors proliferate more, they form more metastases in vivo in the mice, and you find a correlative number of increased circulating tumor cells, which we use to predict metastases in these mice. Obviously, this allowed us to ask a number of questions. What were the extrinsic, so the systemic host factors, and the intrinsic factors regulating this particularly exuberant phenotype? And a number of studies generated in the lab led us to conclude that LDL cholesterol signaling through the LDL receptor on breast cancer cells leads to increased proliferation, increased migration, decreased adhesion, and increased epithelial to mesenchymal transition, allowing, therefore, faster progression of the cancer. Then we studied a few years back in collaboration with a colleague at the IMM whether a systemic altered metabolism could impact on immune response against breast cancer. And in this setting, we studied the importance of gamma delta T lymphocytes, which is a cellular therapy that basically was developed at IMM by Bruno Silva Santos' lab. And what we studied in collaboration with them was whether systemic exposure of gamma delta T lymphocytes to elevated LDL cholesterol levels specifically would affect their capacity to recognize breast cancer cells and to eliminate these. And the answer is yes, it decreases the activation status and the proliferation of gamma delta T cells, and therefore decreases their capacity to recognize breast cancer cells and to kill them. And this is basically very quickly shown here in this particular slide. So all these years of research have led us to a number of conclusions that indeed point to the fact that a systemic metabolic alteration, namely lipids, in patients will increase progression of breast cancer cells by affecting intrinsic properties of the cancer cells and its extrinsic properties. We are leading this forward by studying in more detail a number of mechanisms, but I would like to end my presentation by talking to you about a recent initiative that was developed at IMM, of which I am one of the coordinators, which basically is our idea to try and bring all these different levels of research and knowledge into a common initiative where public engagement and communication of science to the general public is included in this particular initiative. So this is called IMM Lasso Hub. And basically the key questions are depicted here. If you ask whether these are original, they're not really original questions, if you like, but they're absolutely crucial questions at this particular stage, we believe, of research and diagnosis and treatment. Our approach is to do a detailed cartography, if you like, of breast cancer by performing, transcriptomics, genomics, metabolomics, and cellular composition in detail within the tumor microenvironment with the aim of improving diagnosis of the cancers and predicting progression of the cancers and response to therapies. I thank you very much for your attention, and this is it. See, Patricia. Thank you.
Thank you very much, Sergio, for this very interesting talk. Heading towards the end of the second part of this session, I now call Francisco Cavaleiro de Ferreira to the stage. Francisco Cavaleiro de Ferreira is the president of the Portuguese Cancer League, national reference in supporting cancer patients and their families, promoting health, preventing cancer, and encouraging training and research in oncology. Francisco Cavaleiro de Ferreira is an engineer by training, and in parallel to his volunteer work as president of the Portuguese Cancer League, he has also held several executive board member positions, namely, and more recently, as CSO of Multi-Iberia, an European leading developer in real estate and retail. Francisco was also lecturer in team management and in retail at Católica University of Lisbon and holds a post-graduation in management by Harvard Business School. Thank you, Francisco.
Thank you. Good morning to all of you. First of all, thanks for the invitation. It's a pleasure to be here and have the opportunity to speak about the Cancer League and our work. We were requested to speak about quality of life of patients and the action of the Cancer League. I will take 1 minute from Sergio's presentation because he took 5.5 minutes, so I think I have more or less 2.5. So let's go for it. Liga Portuguesa contra o Cancro, it's a public utility institution created in 1941, and we have 4 strategic axes on our action. We have the supporting for the oncological patients, families, and caregivers, the primary prevention, secondary prevention, and training and research in oncology. On the first one, which is the one where we will always have our resources attached, we have the hospital volunteering support for mutual support groups, which is the self-help that you have there, psycho-oncology, juridical support, social support, home support services, patient transports, and cancer support helpline. I think I need a bit of water, otherwise I won't do it. So this is the area where we want miss for our patients and families. Then we have the primary prevention, where we have the health education, awareness of prevention, and relay for life. This is what we have as a priority for the future, and this is where we will put our resources as a second choice. Then we have the secondary prevention with breast cancer screening, where we are doing the breast cancer for all the country with the exception of Algarve, and early diagnosis of skin and oral cavity cancer with around 40 initiatives per year. Last but not least, research grants, training scholarships, training of help technicians, and research congresses. Our first axis, we have a support in a multidimensional that is always based on principles like humanization and solidarity. These are the pillars of our action, and they are supported by values like equity, sensitivity, respect, commitment, transparency, ethics, and responsibility. The impact of our actions is visible and perceptible on the emotional outcome and quality of life of patients, their families, and caregivers. And we have put it caregivers on this group because we do think it's really important. We speak on patients and families, but caregivers are in the same ecosystem. This slide, just to give you something that is really important for us, our framework where we work on, has its boundaries on humanization and solidarity. Everything we do must be done within these values and on these boundaries. We have financing from the population, so we don't have any financing from the state, with the exception of the screening program we have for breast cancer. And we need to be transparent as we are a volunteer organization. Where do we act when it comes to quality of life of patients? Two main areas: initiatives on the ground, so on a daily basis, directly with the patients and their families, and initiatives within the scope of advocacy. Within the scope of humanization and on the ground, we have around 20,000 volunteers in different areas nationwide, and they are organized in 5 groups. Hospital volunteers working in the humanization of hospital oncology services. I will show you we have around 70 services on the hospitals. Community volunteers, people who work on special community programs, namely Relay for Life from the American Cancer Society, which is a program very embedded in the community. Competencies volunteering, this is people like you, like me, people that give their own time to support our action, like physicians, like lawyers, or even psychologists for our appointments. And then we have local community volunteering, so volunteers that work on delegations and support groups all around the country. We are speaking of around 100 points of contact all over the country. We have on the districts installations where we have all the things that we do here in Lisbon, Porto, or Coimbra, and we have then smaller communities spread it all around the country. And last, mutual support. So these are specialized support groups only for relatives, caregivers of cancer patients, as a way of sharing experience, dilemmas, problems, and joint search for solutions and ways of acting. This is people that went through the disease and is available to support others. Very briefly, an example of, we have around 10 hospitals where we are presented, and this is an example of what we can give and what the needs are. So we need to match our capacity of giving something, because we are volunteers. Sometimes we are not able to give what is necessary on an hospital, and the needs of the hospital, depending if it is a central hospital, regional one, local one, whatever. And these are the services we have on the hospitals. On the solidarity side, we have a specific service for economically deprived patients through support in family cooperation, which is financial support, to help with food, transport, and other extraordinary situations. And we have adjuvant medication for oncological diseases, fully or partially not reimbursed by the national system and indispensable for treatment. To give you an idea, this represents something like 1.5 million per year, and it has been increasing dramatically over the past 4 years. So we were on around 700,000 per year. We almost doubled it. Time is running, but I still want to give you an idea of what we do on advocacy. We presented 30 proposals for the National Health Plan. I will select 3 or 4 from the ones that are here. One that I think it's important because it's very easy, just comply with the law. So make effective the existing population-based screening in our programs in our country. It exists, the law is there, but it's not fulfilled. Another one has been spoken here, the awareness based on scientific evidence about the consumption of certain products such as tobacco, alcohol, sugar, or salt. This should be mandatory on our schools, not something that, if you want, you can share with the students, but mandatory, period. Another thing that we think it's really important is to promote the development of a national table of disabilities that aims to hold off the application of the national table of disabilities due to work accidents or occupational illness. I don't know if you have the idea, but there is no table of disabilities for someone that just had a disease. So you are cataloged within the National Table of Disease due to work accidents, nothing to do with the disease, or due to occupational illness. So basically, if you are a teacher, you have a breast cancer, you cannot move your arms, but you have 60% of disability. And if you want to lecture, you just cannot do it because you cannot raise your arm. And this is not tackled for years and years and years because there is no table for a simple disease. So this is something really important for our patients. And it's in the order of the day, and it's a reality. We need to improve the primary health service care because you cannot have early diagnosis, you cannot have screening programs if people do not have the access to the services. And if you are a patient, you are fragile, you cannot go at 5 a.m. in the morning or 6 a.m. in the morning to have a place on an appointment just to have an early diagnosis consultant. So I will leave just these ones. If I need to give you a message, I would say that the first one is the fragility of patients. So for an improvement in the quality of life of patients, family members, and caregivers, it is essential that policymakers and all health professionals always bear in mind the fragility of those who face the disease and the limitations that arise from it. It's the fragility and the limitation. Don't forget it. The pace of today's society, this is the second important thing, does not allow us to put ourselves in other people's shoes, but when we do it, this perspective is always different. And this is again a reality. We speak a lot about it, but we don't do it. It's completely different if we are able to really do it. And the last one that brings together the other two, when we are able to do it, let us never forget that the perspective of the patient, family member, or caregiver is the most important step towards improving the quality of life. So they do know what is improving quality of life. We can speak about it, but in the end, they are the ones that can give us that experience. And we should not forget this. Again, it's very easy to say, it's very difficult to put in place. I will finish with our numbers because if we receive, we must give something, and the only thing we can give is the result of our activity. It's in Portuguese, I'm sorry, but these are some of the numbers. I won't go through them because I think I overpassed my time. Thank you for your time, and I will be available for any question.
So thank you again to all the speakers, and I now invite you for the excellent presentations, and I would like to invite you all to come here to the stage, all that we are only 2 or 3 here. And for a round table, we have prepared some questions, so come here, Sergio. And
Acho que fui buscar bocadinho mais tempo do que minuto.
podemos ver as pessoas que estão online? We are trying to tentar pôr as pessoas online a aparecer. Can we have the people in? So I may continue so that we don't lose time.
O Walter não está, é só o Carlos.
Não? Então, se calhar passamos a fazer isto tudo em português, não? Então, queres passar para a questão?
Vamos passar para português.
Fazes tu a questão, Carla? Não fazemos isto.
Posso
Não fazemos.
Depois faço a questão,
Como o professor Walter teve que sair, nós vamos passar para português, que assim também podemos falar na nossa língua materna, sem necessidade. Portanto, nós tínhamos preparado aqui algumas questões para dar aqui início a uma mesa redonda e, sobretudo, que gostávamos de perguntar como é que os nossos oradores veem nas vossas áreas o que é que teremos que fazer para conseguirmos alcançar um objetivo tão ambicioso como o objetivo que tem a Missão Cancro no fundo, em 2030, deixarmos de ser uma doença tão prevalente. Quer começar, Sérgio?
Essa é para Carla.
Carla.
Sim, estão a ouvir? Sim. Eu acho que é uma missão que pode ser impossível. Pelo menos até 2030. Espero que seja melhor.
Está-se a ouvir um bocadinho mal.
Está-se a ouvir mal. E agora?
Melhor.
Sim.
Obrigada.
Eu peço muita desculpa pelas condições técnicas. O que eu estava a dizer é que a missão pode ser impossível até 2030, mas o esforço que os investigadores estão a fazer é certamente importante e o esforço que a União Europeia fez para gerar esta iniciativa é certamente importante. Eu penso que o exemplo que eu dei da cooperação de Portugal e da Colômbia, sempre é um exemplo do que se passa na Europa, pode ser pode nos fazer pensar nos segredos populacionais de cancro, principalmente aqueles que são mais prevalentes, é importante e certamente a prevenção passa por isso, identificar pessoas assintomáticas que carregam o risco enorme de desenvolver podem ser intervencionadas para falar de cancro.
Ok, muito obrigada, Carla. Não conseguimos ouvir muito bem, mas ficou... Pronto, fica a mensagem. Cá não vale a pena.
Complicado.
Peço desculpa. Sérgio, quer comentar?
Sobre esta questão.
Sobre esta questão.
Obrigado. Olá, Carla. Estás bem? Tudo
Olá,
bem?
Sérgio, não.
Já consegui.
Complicado.
Pois, tem que ser possível. Os desafios são possíveis. Os cientistas, quer dizer, somos treinados para resolver problemas, não para criar problemas. E, portanto, se há um desafio dos policy makers, etc., tem que ser possível. O que é preciso? Evidentemente coordenação, evidentemente financiamento, evidentemente articulação entre os diversos atores do processo, desde as instituições académicas de investigação, os hospitais, a indústria farmacêutica, etc., e depois a comunicação para o público em geral, awareness, há toda uma lista de coisas que já vimos nos vários slides que foram apresentados, que faz acreditar que é possível. É um bocadinho dizer, deixem-nos trabalhar, basicamente. Portanto, se nos permitirem fazer o trabalho, nós não enganamos ninguém, fazemos o maior esforço. Ali vários colegas a rir-se para mim, mas eles pensam exatamente como eu. Portanto, deixem-nos trabalhar da melhor maneira possível, não nos compliquem a vida, de uma forma geral, avaliem, façam as coisas todas, mas deixem-nos fazer as coisas. Há uma leitura, há um exemplo, não é uma leitura que eu acho que é fantástica e que nós, nos alunos de medicina, damos esse exemplo e desde que começámos há uns anos atrás a dar aulas sobre a erradicação de determinados cancros, e nomeadamente o cancro do colo do útero, que é um dos exemplos. Tem havido artigos que não são ficção científica, porque a partir do momento em que a investigação permitiu identificar os subtipos mais prevalentes, desenvolvemos uma vacina, temos programas de rastreio de vacinação, etc., postos em prática, é evidente, parece-nos, que seja possível, se não erradicar, diminuir muito a incidência do cancro do colo do útero, por exemplo. Portanto, isto é exatamente o resultado disso que eu estou a dizer. Para outros cancros que sejam preveníveis, ou pelo menos as principais, a exposição, pronto, etc., etc., ambiental, que seja possível, é outro nível de possibilidade de investigação e de pôr em prática determinadas policies que seja possível, de facto, erradicar. Portanto, deixem-nos trabalhar, deixem-nos fazer coisas.
Além de os deixar trabalhar, que eu concordo com o trabalho, até porque os resultados estão aí, eu punho a tónica em 2 outros pontos. O primeiro é na literacia e na educação, portanto estamos a falar muito de prevenção primária, porque isso faz com que também o outro lado, os doentes, sejam parte da solução, e o parte da solução é os doentes serem mais responsáveis pela sua saúde. Não é só investigar, criar soluções, é também garantir que não é necessário criar algumas das soluções, porque as pessoas têm o empowerment da sua saúde, o que não acontece hoje em dia. Hoje em dia, a maior parte de nós, a saúde é quando temos um problema. E quando temos um problema, há uma entidade, normalmente um médico e um sistema, que tem que resolver o nosso problema. Não pode ser assim ou não deve ser assim. Mas isto só se muda através de literacia, de educação, de sensibilização. Portanto, eu ponho um grande foco nisto. Eu sei que não acontece de um dia para o outro. E, portanto, a missão Cancro tem prazos, mas nós não temos que olhar só para os prazos, temos que olhar para lá dos prazos. O outro ponto, que também, em regra geral, não é focado nestas alturas, eu diria que é a informação e a qualidade da informação. Não se podem tomar decisões, sejam elas quais forem, ou coordenar seja o que for, se não tivermos informação que é fiável e atempada. Eu, como gestor, tomo decisões. As decisões que tomo é baseada na informação que tenho. Vocês, como investigadores, investigam com informação que é fiável, seguramente. Ou então são hipóteses, mas muito bem organizadas. Regra geral, quem toma decisões que impactam a nossa vida não tem a decisão atempada, nem sequer é fiável. E eu dou o exemplo do ROR. A última informação do ROR é de 2018, se não me falha a memória, e mesmo essa informação diz só respeito a 2018, não diz respeito ao que está para trás. A última informação do ROR eu julgo que é de 2012. Portanto, 2012, depois salta para 2018, depois em 2018 existe, e estamos em 2022 e não existe nada. Como é que nós podemos ter a ambição, e eu acho muito bem que tenhamos, a ambição de ter uma missão cancro e ter algo para o nosso país se a entidade que nos dá a informação não consegue dar-nos essa informação? A minha pergunta é como é que vocês conseguem gerir isto? Eu não conseguiria, a não ser levantando o dedo, se calhar, e tentando ver de onde é que vinha o vento. E, portanto, eu deixava estes 2 pontos como maiores preocupações.
Isabel, quero comentar aqui esta, não diria provocação, mas...
Eu não sei quem são os intervenientes que estão aqui, portanto, não sei se estou a fazer provocação direta a alguém, peço desculpas assim é.
Boa tarde a todos, que agora já estamos na parte da tarde. Eu acho que os dados é uma grande preocupação e não vai ser assim tão fácil resolver, até por causa do RGPD, nós não podemos ter assim acesso aos dados, que forma é que tem os dados, quem são os detentores dos dados, isto está sempre a ser discutido. E, portanto, a informação existe. Como, a quem e de que forma a podemos divulgar é que é a questão. E não vai ser tão fácil assim, e é isso que nós também queremos, em algumas áreas, conseguir atingir os objetivos. Para ter uma ideia, nós falhámos no Working Package 7 do EPAC, precisamente por causa disso. Não é por falta de dados, é porque não os podemos divulgar. A nossa legislação não o permite. E, portanto, também não podemos permitir o fácil acesso a tudo e a todos. A questão é como e de que forma. E eu acho que isto levanta muitas questões, tem sido altamente debatido até por pessoas especialistas nas áreas, mas isto é transversal a todas as áreas e a saúde, ainda por cima com os dados sensíveis que implica, ainda mais vamos ter essa dificuldade. Mas que existem as bases de dados e que os dados estão lá, isso estão, porque nós às vezes a nível central conseguimos alguma informação, mas não podemos passar. E nós tínhamos uma ótima solução, que é o RON. Na parte da oncologia era o ideal, Registro Oncológico Nacional, com tudo o que diz respeito à oncologia, inclusive aos rastreios, que deve ser disso que está a falar.
De tudo, não, de tudo.
Mas também é uma das áreas principais que a Liga está preocupada. O problema é que nós sabemos a dificuldade que é fazer o registro no RON, porque há falta de pessoal, há falta de pessoas motivadas, a informação não é colocada como deve ser, embora agora, por lei, já devia estar. Então já temos registros e já está publicado o relatório de 2018. Está-se a tentar melhorar. Vamos ver no futuro se isso é possível. Mas vai ter que ser um esforço colaborativo, mas não se podem dar os dados assim de qualquer maneira. Não sei se respondi à questão. Muito obrigada.
Penso que sim. Hugo.
Posso fazer uma pergunta?
Claro.
Obrigado. Como é que se faz nos outros países? É porque eu vou-lhe passar a minha experiência enquanto dirigente da Liga. Nós contratámos uma DPO. DPO é uma pessoa responsável pelos dados, porque era importante, por causa da notoriedade da Liga, não podemos falhar. E a nossa DPO, eu vou-lhe confessar, mais do que criar soluções, traz-nos problemas todos os dias. Todos os dias. E, portanto, a indicação que lhe foi dada muito claramente é, primeiro, não fala com ninguém sem falar connosco, porque é preciso medir o risco das coisas para não sermos nós os campeões da legalidade, em vez de estarmos dentro da legalidade, que são coisas muito, muito diferentes. E a pergunta que eu faço sempre à DPO, sempre, é como é que os outros fazem? Nós gastamos 36 mil euros por ano na DPO. Eu não acredito que haja muitas associações em Portugal que possam fazer isto. Portanto, como é que elas vivem? Como é que elas fazem? E eu transponho esta pergunta para os outros países. Eu sei que têm mais dinheiro e, portanto, terão outros recursos, mas como é que eles fazem? Este problema não pode ser assim tão complicado dos dados que bloqueie muitas das coisas que nós fazemos. Não é só na saúde, é em todo o sítio e tem toda a razão. Então, a minha pergunta é, nós sabemos como é que os outros fazem e podemos copiar eventualmente o que eles façam de bem, porque o RGPD é, de facto, uma complicação. Por isso mesmo é que eu estou a perguntar como é que os outros países fazem.
Os dados agregados que estão no RON, já há países que fazem isto de uma forma mais eficaz. Não sei se por terem melhores sistemas de informação, provavelmente, ou porque as pessoas estão mais motivadas para o fazer, ou porque têm mais financiamento para pagar às pessoas. Porque o que acontece, por exemplo, para o RON, é que as pessoas muitas vezes não são pagas para fazerem aquele trabalho. É incluído dentro do trabalho normal delas.
Claro.
E isto dificulta tudo. Portanto, a falta de recursos humanos dificulta aqui esta situação. Não sei exatamente como é que cada um dos países da União Europeia funciona, mas eles têm os dados agregados e têm as bases de dados nacionais e que são bases de dados anonimizadas, como nós temos no RON, mas não os podemos dar. Essa é a questão. Não é não existir, é não estar suficientemente preenchida e com a qualidade que nós gostaríamos que tivesse para aquilo que nós pretendemos. Se calhar é uma questão de organização e de financiamento para poder fazer de uma forma mais organizada.
Muito obrigada. Nós depois temos uma sessãozinha de perguntas.
Então, muito obrigado. Obrigado, Isabel, pela intervenção. Eu queria chamar aqui outro ponto à discussão, nomeadamente naquilo que é o processo de investigação, de descoberta de novos diagnósticos, novos tratamentos, o envolvimento dos pacientes. Nós, nos últimos 2 anos, passámos por uma situação de pandemia e vimos os processos a serem acelerados por facilidade por parte das autoridades, como também por maior colaboração, por maior comunicação e maior financiamento também. Eu vinha colocar aqui a questão se, na opinião dos investigadores aqui presentes, portanto, Carla, Sérgio, mas também na visão dos pacientes, qual a vossa percepção, se vai haver um spillover, não só na investigação da Covid, mas para outras áreas de investigação, nomeadamente no cancro, porque ultimamente ouvimos falar muito em novas terapias. As RNA que foram agora para a Covid também existem para aplicações oncológicas, mas os antibody drug conjugates, as CAR-T, enfim, as terapias oncolíticas, etc. Qual é a vossa opinião, também através do papel da investigação fundamental neste processo? Vamos poder ter novos medicamentos, novas terapias, novos rastreios em menos de 20 anos? Carla, passo-te a palavra primeiro.
Se não perceberem, digam-me, parem, não vale a pena. Eu espero que sim, e nós estamos a ver alguns dos ensaios clínicos que duravam cerca de 10 anos a serem reduzidos para muito menor, porque há uma vontade muito grande das pessoas, dos clínicos que fazem investigação, dos investigadores que não fazem clínica, e eventualmente alguns financiamentos, sejam nacionais ou internacionais, que ao conseguir operacionalizar o desenvolvimento de drogas e a aplicação delas na clínica mais rápido. Portugal, certamente, não é um exemplo. Eu acho que nós temos que melhorar muito, mas é a primeira coisa que temos que ter consciência, é que se não estamos bem, mas conseguimos identificar os problemas, isso é um bom ponto para que neste momento estamos nessa circunstância de identificar o problema e começar a trabalhar. Eu tenho tido uma excelente experiência a trabalhar com hospitais, com clínicos. Começo a ver nos clínicos uma vontade muito grande de trabalhar em investigação e de participar em projetos de investigação. Tenho o apoio de associações de doentes. Os doentes contactam para serem alvo de investigação. Portanto, eu acho que temos tudo que precisamos para avançar.
Sim, se posso complementar, é um pouco o que a Carla disse, mas vamos lá ver, o processo de investigação tem os seus timings e demora. Isto é algo que, mais uma vez, na própria literacia, acaba por ser um aspecto importante de explicar. Tive a ocasião, como alguns dos colegas presentes, durante os anos da pandemia, de fazer algumas sessões de esclarecimento sobre o funcionamento das vacinas e como é que foram descobertas, e explicar às pessoas que a descoberta a possibilidade de produzir vacinas num intervalo de tempo tão pequeno não foi gerada em 2 anos, ok? Portanto, isso é muito importante explicar às pessoas. O processo de investigação demora o seu tempo. E depois, e eu creio que acabamos por, nos vários assuntos que estamos aqui a discutir, por tocar na profissionalização de todos os recursos, para haver uma transferência de descobertas que sejam realizadas no laboratório para ideias patenteáveis e depois, finalmente, que isto possa resultar num processo que leve à produção à geração de um produto, seja ele para diagnóstico, para tratamento, etc., precisamos de estruturas existentes, de pessoas, de estruturas nas instituições de investigação que nos permitam fazer essa passagem. E eu creio que em grande parte das estruturas de investigação em Portugal nós não temos essa capacidade instalada. Eu recordo-me perfeitamente, há muitos anos atrás, trabalhando no estrangeiro, de haver a presença habitual de pessoas do que agora se chama, e existem em algumas instituições, nomeadamente a instituição onde eu neste momento trabalho, os Technology Transfer Offices, assim, um nome um bocadinho pomposo, mas que são os tais estruturas e capacidades que nos permitem fazer a passagem. Muitos investigadores, pela própria natureza do trabalho, somos, regra geral, pessoas curiosas e com atenção ao detalhe, etc., etc. Mas a capacidade de percebermos se uma determinada descoberta é possível ser aplicada num determinado produto não existe em todos, certamente. E, portanto, eu creio que, para além de evidentemente, ter que haver uma sustentabilidade do processo de investigação e a compreensão por parte do público e dos doentes, etc., de que isto tem o seu timing, precisamos de estruturas que nos permitam fazer essa passagem, para termos mais descobertas, mais depressa, e depois, como tocou no assunto, a parte de legislação e de aprovações já não depende de nós exclusivamente, da parte dos investigadores. Portanto, penso que isso ainda é outro nível.
Portanto, compreender que tem uma visão positiva de que, ainda que não seja para amanhã, é possível. Exato. É possível lá chegar com. Pergunto também então ao Sr. Engenheiro Cavaleiros de Ferreira se, na visão dos pacientes, a pandemia teve algum impacto negativo, nomeadamente no atraso de algumas consultas e de rastreios e afins, que, tanto quanto eu sei, tem vindo a recuperar esse passo. A médio e longo prazo, imagina que esta nova velocidade e estes novos processos que foram, entretanto, implementados poderão beneficiar a comunidade de pacientes oncológicos?
Sem dúvida que podem. O haver mais conhecimento é sempre benéfico para todos, seja em que área for, porque hoje em dia tudo se toca e, portanto, pode-se aproveitar muita coisa de áreas em que nem pensávamos que iria ser utilizado para outras. O micro-ondas que nós temos em casa foi por causa da ida à Lua. Não tem nada uma coisa a ver com outra, mas é importante. No caso da investigação, só há algo que, do ponto de vista dos doentes, preocuparia um pouco neste acelerar dos processos. Nós vivemos às vezes de mitos ou de crenças, e isto não é um mito ou uma crença, mas o facto é que o aparecimento de novos tratamentos e novos medicamentos tem que levar tempo para ser testado. É difícil convencer uma opinião pública que aquilo que levava 20 anos, de repente, passa a levar 2 ou 3. Como disse, é trabalho que já estava feito, mas essa mensagem se calhar não passou, mas não se convence uma opinião pública que uma coisa que levava 20 anos agora leva 2. Ou pode-se ir convencendo. E o maior risco que se corre nesta transição é se porventura algo falha e então a fiabilidade de tudo aquilo que existia desaparece. E a partir daí, eu não digo que é o caos, mas a partir daí é muito mais difícil de buscar novamente as pessoas. Eu tive 10 minutos naquela sessão global, não sei, plenária, e naquela sessão dizia-se uma coisa que eu acho muito interessante nos 10 minutos. Portanto, imagino que o resto possa ter sido interessante. Que era, não se faz nada sem a colaboração do resto da sociedade. E, portanto, há um grupo que desenvolve, que investiga, que põe em curso, que comercializa, etc., etc., mas se a sociedade não aderir, como se viu no Covid, em algumas fases, é um problema sério.
Sim.
Portanto, o quebrar a confiança e a fiabilidade de um processo, eu diria que é preciso ir com alguma prudência, mas quem sabe da coisa é que deve medir qual é a rapidez deste processo, mas saltar de um extremo para o outro parece-me um bocado perigoso.
Ok, muito obrigada. Vamos muito rapidamente passar à audiência e penso que existem 2 perguntas, uma aqui na primeira, 3 perguntas, temos que ser muito rápidos.
Então, bom dia, muitos parabéns pela sessão, acho que é muito interessante. Que sou Cristina Vaz de Almeida, da Sociedade Portuguesa de Literacia em Saúde. Só fazer um pequeno enquadramento. 50% da população em Portugal tem baixa literacia em saúde. 50%. Não conseguem aceder, nem compreender, nem usar os recursos de saúde. Compreendo que a disponibilidade dos dados às vezes é restrita, como foi aqui dito. No entanto, a participação do cidadão é essencial, como diz o Dr. Cavaleiro Ferreira. A minha pergunta é como é que nós conseguimos, por um lado, qualificar o acesso, que é um dos objetivos, maior equidade, ou seja, como é que isto é obtido. E eu penso que tem que ser feito aqui um caminho, como há muita investigação publicada na área oncológica, e o cidadão precisa de saber, se nós não devíamos fazer aqui, já para a investigação publicada e disponível, fazer aqui uma transferência para uma linguagem mais leiga, mais entendível pelo cidadão. E talvez isso seja o passo inicial para compreender. Os cientistas estão sempre com pressa na investigação e não gostam de revelar os dados, mas há muita investigação dentro da área oncológica que se calhar o cidadão beneficiaria nesta transferência da linguagem complexa para a linguagem leiga. E por isso a minha pergunta é como é que conseguimos este objetivo da maior equidade no acesso?
Eu posso dar um exemplo de 2 coisas que estamos a tentar fazer. A primeira, eu falei ali um bocadinho sobre o tabaco, o álcool, o sal, etc. Porquê é que isso não é obrigatório na disciplina de Biologia ou de Educação Física? É uma matéria de legislar, nada mais. O esforço que nós fazemos para chegar a 350 mil alunos, que é o que conseguimos fazer neste momento, se calhar é muito mais fácil se for legislado, for implementado. Portanto, parece-me que há também aqui alguma literacia ao nível de quem decide, politicamente, para que possam implementar algumas das medidas. A outra, porventura mais técnica e mais difícil, porque falou em investigação. Eu acho que era muito interessante e nós estamos a tentar fazê-lo, não sei muito bem ainda como, porque o difícil é traduzir. Os doentes não sabem quais são os ensaios clínicos que existem. Eles sabem que existem e, portanto, como é que acedem a eles? Normalmente é o seu médico que anda à procura de um determinado tipo de doentes ou de doenças, que identifica e que lhe pode propor um ensaio clínico. Eu acho que seria muito importante para os doentes poder haver um local, e nós, Liga, estamos disponíveis para ter isso no nosso site, porque estamos a tentar montar isso, onde estejam todos os ensaios clínicos, obviamente filtrados por uma entidade nacional, porque eu julgo que existe, não sei se será o Infarmed ou será alguma outra entidade, mas, no fundo, inverter o ciclo, que é as pessoas que são os mais interessados, que são os doentes, terem acesso à informação e, com isso, aumentar-se a acessibilidade e a equidade no acesso aos ensaios clínicos. Porque hoje em dia tem acesso, eventualmente, quem está mais próximo do seu médico ou quem tem um caso mais específico que se adapta melhor e não o contrário. Devia ser o contrário. Todos deviam ter acesso e depois deve ser feito o filtro para aqueles que podem e não podem, são ou não são elegíveis.
Só uma pergunta a mais, já fomos avisados, temos mesmo que encerrar a sessão, infelizmente. Gostávamos de estar aqui mais tempo na conversa e a discutir estes temas que são tão importantes e interessantes. Não sei, quem tem...
Bom, muito bom dia, boa tarde a todos. O meu nome é Maria Paula Macedo, Universidade Nova, Nova Medical School. Eu gostaria de dar os parabéns pelo Hub, por esta transferência europeia. O que eu não consegui ainda materializar, e por falta de conhecimento com certeza, é como é que a AICIB está a fazer o enquadramento daquilo que é a relação dos investigadores com os clínicos, com os doentes e com os centros académicos. Se calhar, doutora Patrícia.
Obrigada, Paula. Eu acho que a resposta rápida não está. Não. Gostaríamos muito e talvez lá cheguemos um dia. O que a AICIB se propôs fazer, em coordenação, vou olhar para a minha colega, aquilo em que nós temos vindo a trabalhar há um ano e qualquer coisa, foi em montar uma estrutura que pudesse apanhar o que vem da União Europeia e ajudar a passá-lo para o país. Nós não vamos conseguir, pelo menos neste momento e com os recursos de cada lado, fazer tudo o que a Paula referiu, que me parece muito bem. Por isso é que lançámos o desafio aos stakeholders, a quem se juntou a este grupo, que nos deem essas ideias. Porque se queremos criar esse tipo de redes nacionais, é possível, nós podemos ajudar como catalisadores, mas precisamos, quem está nessas instituições, de propor ações concretas e de nos ajudar e de propor um plano e força de trabalho. Nós não chegámos aí ainda.
A pergunta específica é se vai haver ligação entre o Hub e os centros académicos.
Os centros académicos clínicos devem estar no Hub. O Hub é uma plataforma aberta para quem...
Com todo o respeito, eu se calhar sugeria continuassem a conversa depois desta sessão, uma vez que já começou aqui um diálogo e gostaria... No final da sessão poderão, com certeza. Neste momento temos que encerrar. Não posso permitir mais continuar a sessão. Agradeço a todos os oradores presentes, presencialmente e remoto, e a todas as pessoas na audiência. Muito obrigado por terem vindo.